Hi, this is Dr. Peter So, and today I'll talk about headache. I've done this lecture several times and have noticed that afterwards I have audience members asking about headaches and sharing their personal stories or family stories of friends and family having headache. I think headache is one of those disorders that is not taught that much in medical school or in residency and is actually a problem that affects many people in this world. So I hope this provides some more information from a medical student perspective and learning, and also those who are interested in headache or other providers who like to treat headache. I have no disclosures. So I'll talk about migraine headache, diagnosing, managing. We'll go over cluster headache, one of the trigeminal autonomic cephalgias, tension headache, and other headache disorders. So headache's interesting because it affects about 15% of the world population, which is about 1 billion people. It's the third most common disease and sixth most disabling disease globally. The prevalence is highest during peak productivity years between the ages of 25 and 55. So from an economic standpoint, there are a lot of costs that are indirect and direct. Severe migraine affects about 38 to 50 million Americans with a female to male ratio of 3 to 1. To put it in perspective, this is more people in America that are affected by severe migraine than people with diabetes or osteoarthritis or asthma. Costs per year are $36 billion due to medical costs and the costs of missing work. And this is why headache is such an important thing to take care of and manage, because there are so many therapies now, especially new therapies, that can help these symptoms and let people enjoy their lives and work productively. Um, it's one of those conditions that, left untreated, you do have a lot of lost time of quality of life. You can't even read, you can't eat, other basic things that you could do, you just can't do with a migraine headache. Diagnosing headache is really important. It's a clinical diagnosis. Therefore, the history and physical exam are the most important. There's no serum marker or imaging modality that can diagnose it. Basically, you want to always get an onset of when it started, how soon it started, the duration, frequency, the type of pain that's associated, and how the pain, if it radiates, and also associated symptoms that are classified as premonitory, before the headache, and prostrome, which is after the headache. Alleviating aggravating factors are important as well. With diagnosing headache, the International Classification of Headache Disorders provides a criteria for clinicians to follow to make headache a more quantifiable disease and diagnosis. One important thing with headache management is having a headache diary for the patient. Each day, a patient logs if they've had a headache and what medications they took, the type of headache, and any characteristics that may have triggered a migraine headache attack, such as they had a glass of red wine, or there's a combination of things that may have happened, like previous night's sleep, stress, or even caffeine withdrawal or intake. The headache diary is important because it's a clinical diagnosis. On follow-up visits, the patient can then provide good data to the clinician to see if whatever treatment's working, to notice patterns of the headache to help better manage them. This is a website, ICHD. You can go on the internet and they're on the third version of it. You first want to classify which kind of headache group the patient belongs to. So we have migraine headache, we have type headache, and trigeminal autonomic cephalgia are the big categories. You also have other very specific headache disorders. There's a lot of more rare headache types. You want to diagnose based on their current symptoms. For genetic disorders, the occurrence just during the whole lifetime of that patient. And each different type of headache can be diagnosed differently, specifically if you're diagnosing with coding. So migraine without aura, a migraine with aura, or medication overuse headache can all be within one patient, and that needs to be documented in the charts. So when diagnosing headache, the first thing to do is you want to rule out any red flags. And there's a mnemonic called SNOOP, SNOOPPP, and the piece can go on depending on which SNOOP you use. But essentially, If you have a headache and there's systemic symptoms for the S, and that includes fever, then you want to be careful that this may not be just a primary headache disorder. When you're thinking about headaches, you're thinking about headaches that are either primary, like we just mentioned in the classification, or secondary headaches. So having a fever and other systemic sick symptoms, you want to look out for other things such as infection or non-vascular intracranial disorders. Uh, N would be a neurological deficit that could be related to something centrally causing that, like a vascular malformation. Neoplasm history would also be N. O is the onset of the headache, if it's a sudden or abrupt headache. If the headache is maximum intensity at the onset, you're really concerned about a subarachnoid hemorrhage. Usually, primary headache disorders don't happen all of a sudden with maximum intensity and then last and very abrupt. They usually gradually build up, maybe 5 to 15 minutes or more. Older age, if a patient doesn't have a history of headache and all of a sudden after age 50 years old, they have a new onset headache, that's something that you want to be concerned about. You want to be concerned about maybe giant cell arteritis, neoplasms, etc. P now has many different things, but essentially anything that's causing increased intracranial pressure, so pattern change, uh, positional headaches. When I say pattern change, I mean the headache is not like its typical past. There's some type of change in the quality of the headache, the frequency. If there's papilledema, which also indicates increased intracranial pressure. So secondary headaches, these are headaches that are related to other causative disorders. And this is just the ICHD criteria. If the headache is significantly worsening in parallel with the worsening presumed disorder, or if it's improving when the underlying disorder is improving, is one of the criteria. An example of this would be subarachnoid hemorrhage, and you have to have other evidence that does not exist, or it does exist because of other causes like GCA. Now let's talk about migraine without aura. And when you go through the ICHD classification, duration is really important. So with migraine, 4 to 72 hours is a duration for classification of migraine. Also, it has to have two of the following four characteristics: unilateral, pulsating quality, moderate or severe pain intensity, or aggravated by regular physical activity. So two of those four. And then at least one of the following, which is nausea and or vomiting, or photophobia and phonophobia, sensitivity to light or sensitivity to sound. That's really important because letter D is kind of the migrainous aspect of a migraine headache, which helps distinguish it from a tension type headache. So always think about duration, 4 to 72 hours, two of the following four characteristics under letter C, and any migraine symptoms like nausea or vomiting or photophobia, sonophobia. Now there's migraine with aura, and aura can be any neurological symptom that reverses. It can be visual, sensory, speech. Most commonly, it's visual. And here's the criteria for aura. What's important to know is that it's going to be reversible. You want to make sure this is not a stroke. And the criteria says 3 of the following 6 characteristics. You can read this over. This is just the criteria for migraine aura. So most common aura is visual, and followed by sensory. And then you can also have aura, which is motor, so you loss of strength, like a hemiplegic migraine or brainstem. This is an example of visual aura where you have scintillating scotoma, and you can see these are visual changes that patients with migraine with aura may experience. The premonitory phase is a headache phase that lasts up to 72 hours before the headache, and patients may have tiredness, irritability, reduced concentration, phonophobia. And headache is interesting because the pathophysiology is very complex and it evolves over every few decades or decade. We get a new theory. Some of the older theories was that it was a vascular change and that's what caused the headache, but the newer theories are more along the line that this is related to CGRP and it's a pain pathway that can happen with vasodilation, but it's not the vasodilation causing the migraine headache. The postdrome of headache is the symptoms that the patient feels after the headache. So this is hours or days, and they usually feel unwell, usually tired, concentration difficulties. To better understand the pathophysiology, I recommend this article. This is by Dr. Goadsby and al. And it kind of explains some of the biological changes as well as the changes we see on imaging on the different parts of the brain during migraine in animal models as well as human models. And it makes sense why a migraine involves very different parts of the brain and brainstem. And for example, the hypothalamus may be the reason why we get a lot of yawning or appetite changes, tiredness, concentration problems prior to the migraine pain in the premonitory phase, and the pain in the lateral, the frontal, parietal, temporal areas is related to the trigeminal vascular system. And some of the autonomic symptoms like the running nose, the watering eyes, that comes from the superior salivatory nucleus. And these pathways are all connected, and a lot of the treatments now are targeting these different pathways for migraine patients. So for migraine disorder, there's episodic versus chronic. And this is important because there's different medications that have been FDA approved for patients who have greater than or equal to 15 days per month. Family history is very helpful. A lot of times patients may have, for example, their mother may have had a history of migraine. That's commonly seen in the clinic. Triggers such as missing sleep or skipping meals are common, and other triggers can be found through the history. In neurology in general, the history and physical exam is the most important thing, and imaging and lab usually is supporting and not the main piece of data or information you use to make the diagnosis. So the headache history, when did it start? Was it gradual? Was it sudden? At what age? Because headache can start actually at very young ages in the pediatric population. Where is the pain located? Does the pain radiate? And how long does it last? And you know, from at least from the previous criteria of migraine headache, that duration of 4 to 72 hours kind of puts it there. But as we get to other headache disorders, duration actually changes not only the type of headache, but the management. Does it worsen with movement? Laying down, if it always gets worse laying down, then you may be concerned about pressure changes intracranially. Is it disabling? And this helps you understand what kind of treatment the patient may need, if they need a preventive treatment. Also, it helps you manage and monitor the patient as they follow up. Any other associated symptoms are migrainous, any triggers, and anything that helps with a headache, and then also family history. The Migraine Disability Assessment Test is called MIDAS, and this is just a sample scale of how you can quantify how a patient's progressing on their follow-up visits. And it essentially just asks, how are they been doing the last 3 months? How many days are they missing work or school? How many days are they up to 50% of their ability? And you get a total score, MIDAS score, and you can kind of use this to see if the patient's progressing, if they're worsening, or what their baseline is. Headache diary we discussed, and this helps not only you see the progress of the patient, but it teaches the patient on the types of headaches they're having. A lot of the time, patients with migraine headaches also have non-migrainous headache, and when they can figure out what they're having, and they have an armamentarium of medications to attack their headaches, they know what they can use for different types of headaches. So it actually engages the patient more in their care. An important question is, when do you start prevention? And this is just a recommendation. So definitely, if they're having at least 3 headache days with severe impairment or Coin-Bed rest, they need to be on a preventive medication. And then how do we start prevention? And we'll talk about some of the headache prevention medications. So you first start at a low dose, because every patient is different, how they, with the pharmacodynamics and kinetics. And you want to start at a low dose. You want to give a preventive medication an adequate trial of at least 2 months, and it needs to be at a therapeutic level. So if you're titrating up, you want to then titrate at a certain level that's therapeutic, and then wait, and then give it for 2 months. And then follow up is very important to figure out what's going on. A lot of the medications also have side effects that can be tailored towards the patient's health history. So, migraine management also includes addressing lifestyle, poor sleep hygiene, such as going to bed late and getting a lack of sleep, or going to bed with a lot of electronic devices on, which actually activates the brain and prevents you from falling asleep. Those are things you can address that are non-pharmaceutical that really improve patients' health. Caffeine intake is another thing. A lot of medical students and residents are drinking a lot of caffeine because it helps them perform better or stay awake. But this can also be a trigger for headache, or a cause for caffeine withdrawal headaches. Preventive medications, we have different classes. We now have a new class called CGRP inhibitors. CGRP stands for calcitonin gene-related peptide. And these are the first novel class for migraine prevention. The other medications work very well too, the antiepileptics, antidepressants, beta blockers, and also nutraceuticals like magnesium or riboflavin. Then we also have our abortive medications. These are the medications you have for migraine attacks. So NSAIDs, acetaminophen, the triptans, CGRP inhibitors, and also the devices like transcranial magnetic stimulation and peripheral nerve stimulators. We'll talk more about these in specifics, but dosing is very important. So with prevention, the antiepileptics, we have Depakote and topiramate. These are anti-seizure medications that are not FDA indicated and level A for migraine prevention. Beta blockers are also level A, metoprolol, propranolol, atenolol. And antidepressants, amitriptyline, venlafaxine. If a patient, for example, has trouble sleeping, amitriptyline is a nice preventive medication that will help with sleep at night. If a patient is overweight, which is more often in the developed countries, Topamax or topiramate, generic name, is an anti-epileptic drug that actually has a side effect of weight loss. Some other side effects of topiramate include kidney stones, low risk of kidney stones, as well as very, very rare cases of acute angle closure, which is an emergency, and you gotta stop the medication, or otherwise the patient can lose their vision. Botox is another approved treatment, and it's on botulinum toxin A, and that's the PREEMPT trial for migraine prevention. Also, have the neurostimulation. And then the new ones are the CGRP inhibitors. That's aranumab, Aimovig, Emgality, and Ajovy. The Aimovig, that is a blocker of the CGRP receptor, and Emgality and Ajovy block the CGRP molecule. So with acute treatment, stratified care is very important. This is the model that you entrust the patient with determining which attacks will respond to different treatments. And as I was mentioning with the headache diary, it gives them the autonomy to make the appropriate treatment based on their personal experiences and preferences. Versus the other models where you're giving a patient one medication, they take that, they follow up in 3 months, 2 months, and say it doesn't work. They got to start another medication and follow up. It extends their headache if it's not being managed appropriately. Or the other model is giving them one medication and then letting them wait and then take another medication, and it's not addressing the headache immediately. And really the goal is that the patient needs to figure out what kind of headache they're having based off their preferences and experience, and then attack that headache as soon as possible with the best therapy. And the stratified care approach is the best way to do that. So abortive medications are acetaminophen level A. It's important to note that's 1,000 milligrams at once. A lot of times patients won't take that much, but 1,000 milligrams at once, and no more than 2 to 3 days a week for risk of medication overuse headache. Uh, NSAIDs, and that would be, for example, naproxen is level A. The triptans, which we talked about, there's different kinds. There are also different formulas or methods of delivery. So there's oral triptans, there's intranasal, subcutaneous. They all have a little bit different half-life depending on how, or Tmax, I'm sorry, depending on how you deliver the medication. The one thing you have to watch out for with triptans is that, so their mechanism is that are 5-HT1B serotonin agonists and 1D. The 5-HT1B causes vasoconstriction, and 5-HT1D actually blocks the pain pathway in migraine. So if a patient has coronary artery disease, the triptans are contraindicated. There's a theoretical contraindication for patients with ischemic stroke, but no trials have been done with that. So with triptans, you want to avoid patients with the cardiovascular disease. The triptans are a derivative of the ergots, so dihydroergotamine can be used acutely. It can also be used for status migrainosus and in supervised setting. You have to be careful for heart arrhythmias. And then you can have combination therapies as well. And this comes from the AAN, this table, and their continuum issue for headache. AAN stands for American Academy of Neurology. One medication we absolutely try to avoid are the opioids. Um, Opioids are known to cause chronic pain, and there's very, very rare cases where we'll prescribe opioids. Generally, in the clinical setting, inpatient setting, we give opioids to patients with secondary headaches due to intracranial hemorrhages. Also, a lot of times Eschic or butalbital medications with acetaminophen and caffeine are prescribed in general practice, and these are not good because they usually end up causing rebound headache in patients. Here are some of the devices. It's a transcutaneous supraorbital nerve stimulator. As you can see, that it triggers the trigeminal ganglion, which then goes in the brainstem pathway. It connects to trigeminal cervical complex and then to the thalamus. So this kind of shows how this works. Transcranial magnetic stimulation. And see how the pathways, they go back to the thalamus and other areas where the different parts of the different aspects of the headache are related to different areas in the brainstem and the brain. Vagus nerve stimulation, and the new device is remote electrical stimulation that triggers the peripheral nerve. They have pretty good study findings. The only drawback is that most of these devices are not under insurance coverage, but they are coming down in out-of-pocket costs. So one of the CGRP inhibitors was just approved, and this one's called ubrogepant. It's part of the gepant medications, 100 milligrams, and this is good for an abortive medication for a patient who has cardiovascular risk factors. The CGRP inhibitors are not associated with vasoconstriction, even though during migraine, CGRP and vasodilation happen concomitantly. With pregnant patients, this is a common reason for neurological consult. There's a lot of medications that are contraindicated, such as valproate because of neural tube defects. Even now, magnesium sulfate is a level D because of theoretical loss for bone loss in the fetus under high amounts under IV. Generally, acetaminophen is okay. Nerve blocks, occipital nerve blocks of lidocaine is okay, as well as ondansetron. But there's no level A evidence, and it's probably because pregnant patients are not going to be put under those type of studies. So 5 tips for successful acute treatment of migraine. You want to first make sure the headache disorder is correctly diagnosed. And this can be done through a good history, as well as looking at the ICHD criteria. You also want to use evidence-based recommendations as a guide to select individualized treatment. You want to optimize the treatment, and oftentimes the clinical performance exceed the clinical trials in terms of results. And here are the different triptans with the different onsets. So sumatriptan, the injection has the quickest Tmax, 0.2 hours, and that's right here. For example, naproxen is another good NSAID, and that has a half-life of 14 hours. Back to the triptans, elatriptan is associated with not being in the breast milk, so that might be an option for a pregnant patient. So when you're treating a patient, you always want to assess the response to treatment. You never want to ask them if the treatment's working. It's a very non-specific question, but ask more specific questions like the speed of onset, the degree of improvement, any recurrent headache, and how tolerable any side effects. The mTOQ-4 migraine treatment optimization questionnaire helps assess responses to acute treatment by asking very basic questions and then the final score. And if the score is a 0, it's very poor treatment efficacy, and an 8 would be a maximum treatment efficacy. These are just ways to quantify progress or any results. And you also want to troubleshoot suboptimal responses to treatment. This is good because you don't want to have to change a medication if you find out they're delaying the treatment. For example, with the triptans, you want to do it at the onset of the headache and not wait, otherwise they're not as effective. If they're not repeating a triptan treatment, you usually can prescribe another tablet 2 hours later. Or if they're not delivering the treatment correctly or inadequate dosing. So these are things that you need to figure out before you want to change treatment management. Next, I want to talk about the trigeminal autonomic cephalgias. These are a different type of headache disorder that have autonomic symptoms. And I'll just talk about cluster headache. This is something you'll probably see on your board exam or maybe on any type of medical exam. Migraine headache tends to be on there. Tension type headache are the 2 most common headaches. And cluster headache's actually very rare, but they still ask about it. The other ones, paroxysmal hemicrania, SUNCT and SUNA, and hemicrania continua, they pretty much, if you look at the scale, they change by the frequency of the headache from anywhere from 1 to hundreds per day to 1 per day, and also the duration and how long these occur. So, the cluster headache may occur from minutes to hours. The SUNCT-SUNA is literally seconds to minute, and hemicrania continua occurs for months. So cluster headache, let's talk about duration. It's 15 to 180 minutes. They're unilateral pain, which is either like orbital, supraorbital, or temporal, or any combination, and occur from anywhere from once every other day to 8 times a day. It's associated with autonomic symptoms, so eye watering, eye redness on one side, nasal congestion, meiosis, edema. And the big clinical things is that the patient has these in a clustered period. So it could be like, for example, every March in the spring, I get these headaches, and they're the most severe pain. And actually, the pain is considered to be the worst of all the headache pains. Cluster is the most severe. It's said to be on the level of a kidney stone or childbearing. And also the patient is very restless. They're very agitated. They might be pacing the floor. Whereas in migraine headache, the patient wants to lie down in a cold, dark room. With cluster headache, the ratio is actually reversed. It's 3 to 1 male to female, and migraine is female to male, 3 to 1. Typical age onsets between 20 and 40 years of age in cluster headache. And then you can have either episodic versus chronic. The circadian or circannual pattern is very notable for cluster headache, and that relates back to its pathophysiology with the hypothalamus. They've done imaging, they've done biomarkers and lab studies, and the likely three systems involved are the hypothalamus, the trigeminal vascular system, and the autonomic system. And this is why different therapies work. Oxygen works, CGRP. So this is kind of just a recap. The pain is very excruciating. They're pacing the floor. The attacks occur in series in a cluster of or bouts, and that can last for months or even years. And also, there's triggers, usually within 1 to 2 hours uh, of drinking alcohol, heat or exercise, noxious smells can trigger this. Interestingly, when they're not in the cluster period, these triggers have no effect. In practice, sometimes you'll get a patient who saw maybe a general provider and they're diagnosed with some type of sinus headache, and they were given antibiotics and steroids, and this is like around March. So maybe that was, they thought maybe it was some allergies, sinuses, and then they get better. It's likely due to the steroids, the reason why they got better. But really, this is diagnosis. If you get this good history, you can probably diagnose this as a cluster headache. So this is just the ICHD criteria. To recap of what we talked about, you have episodic versus chronic. So treatment, high flow oxygen 100% via non-rebreather mask at a rate of 12 liters per minute to 15 liters per minute. And that's important, that flow has to be very high. I can do that for at least 15 minutes. For prevention, verapamil has been suggested. And when doing that, you want to first get an ECG to monitor the PR interval on someone who started verapamil. If you're not sure if it's a cluster headache, you can do an indomethacin trial, and this can help rule out other trigeminal autonomic cephalgias, such as like hemicrania continua. And then also subcutaneous triptans are used for cluster. And this is just a chart showing the different treatments. Recently, one of the new CGRP inhibitors for migraine prevention, Emgality, galcanezumab, is now approved for episodic cluster headache. And the dosing is 300 milligrams initial loading dose, followed by 120 milligrams monthly. So episodic versus chronic, and that's a new use for this medication. So let's do a quick case presentation. 32-year-old man reports a 4-year history of excruciating headache. This occurs for 2 to 3 weeks each spring. The pain is stabbing in the left orbital and temporal area 1 to 2 times per day. Each attack lasts 45 to 90 minutes, and it's associated with left-sided conjunctival redness, nasal congestion, and lacrimation. He's unable to sleep or even lie down during these attacks. Which one of the following treatments is most appropriate for this patient when his headache occurs? So it's a male. It happens every spring. It lasts 45 to 90 minutes. It's in one area, and you have autonomic symptoms. So this sounds like a cluster headache, and it gives a lot of information in this vignette to make the diagnosis based off the criteria. So we think it's a cluster headache. What's the most appropriate treatment when this headache occurs? So acute treatment. And in this case, like we said, 100% oxygen, 12 liters per minute, up to 15 liters per minute would help. Next question, which of the following drugs is the first-line preventive agent for cluster headache? We talked about verapamil. Of these four, oxygen would be an acute treatment. Topamax is a good treatment for migraine headache. So next is tension type headache. This is very common. This is probably the most common type of headache. It's a lifetime prevalence between 30 and 78%, and it also has a high socioeconomic impact. This pretty much is the ICHD criteria that I would just focus on, that when you go to letter D, you don't have any of the migraine symptoms. And there might be some overlap in terms of pathophysiology between tension type and migraine headache, but the treatment does change, is a little bit different. So it's important to diagnose the two differently. Um, in letter C, you could have two of the following four characteristics: bilateral location. In migraine headache, it's unilateral. However, in migraine headache, you can still have bilateral and fulfill other criteria and still be a migraine headache. So not everything is always black and white and set in stone. The tension type headache is generally bilateral. It's non-pulsating quality, mild or moderate intensity, and it's not aggravated by routine physical activity. So this is different. Some of these are opposite of migraine headache. And it can last anywhere from 30 minutes to 7 days, which is the duration is different from 4 to 72 hours. Letter A just talks about the different types of episodic tension type headache. One that can be infrequent, frequent, or chronic. So when you're managing tension type headache, you want to really regulate someone's schedule. And that's not just for tension type, like that's for all their other headache disorders as well. The regulation of sleep, meals, and exercise are very valuable. Stress management and avoidance of stress triggers, and also passive the physical manipulation such as massage or physical therapy can help. Some recommendations for abortive therapy: acetaminophen, 500 to 1,000 milligrams, aspirin, ibuprofen, naproxen. However, this should not be done more than 2 or 3 days a week because of medication overuse headache risk. So this actually should be prevention, not abortive therapy. And this would be amitriptyline, for example, would be a way to for tension type headache prevention. Let's now talk about medication overuse headache. This is when there's consumption of acute medications more than 2 days per week with high headache frequency, and chronic opioid use, butalbital can cause chronification, and the way chronic opioid affects the pathophysiology is increased peripheral expression of the CGRP and dynorphin. So for medication overuse headache, it's usually the development's linked to the baseline frequency of headache days per month, the class of acute medications ingested, the frequency of these medications used, and other risk factors. If you use less specific medications for severe migraine, this can transform headaches from episodic to chronic. Because these medications are inadequate, they might start using them more often. And medication overuse headache usually signals that a patient has episodic migraine, but with proper treatment, the patient can reverse to an improved, or an episodic pattern can be improved. The criteria in ICHD is headache occurring in greater than 15 days with a pre-existing headache disorder and a regular overuse for greater than 3 months of one or more drugs that can be taken for acute treatment of headache. Even if I have a patient who is not taking medication every day for more than 3 months, or maybe for the last month, and they're having a rebound headache, I'm still going to have them wean off that daily medication. So you don't have to wait for this diagnosis to start giving them suggestions and medication modification advice. So the treatment is you want to completely wean off the overused medications. You want to establish a preventive medication or behavioral preventive strategy, and then also educate them on providing acute medication limits to prevent overuse, and also educate the patient and the family so they all understand what's going on. This is just a medication overuse headache management for either you want to do a slow wean or an abrupt wean. And between terminating the acute medication and then starting them on a preventive or that transition period, there's different ways of managing it. You can also use steroids. You can use NSAIDs, a different class of medication to help bridge the rebound headache. This is just a summary of what we just said. Also, provide them the tools that if they do have a severe migraine, that they get another type of acute treatment to treat that. So if they were taking, for example, NSAIDs every day, we'll give them Tylenol as the acute treatment and the right dosage. Lastly, this is uh, just a source for clinicians or even people who want to learn more about headache disorders. The American Headache Society, go to their website. Uh, you can go to source for clinicians, and each one of these boxes right here, if you click on it, it'll either provide a PDF or a document that has an expert talking about that topic. So I recommend this if you have more questions about headache management or understanding headache. If you have any questions, you're free to email me. And thank you for listening to this. And I hope this gives you some more information on migraine. There are a lot more different unique types of headaches that can be diagnosed, but this is just kind of a good general overview of some of the more common headache disorders. Thank you. Bye.